I will give you a review of these uncommon or rare tumors. So hope is the only thing stronger than fear. So this is a very good caption for people suffering from bone cancers. Metastatic bone tumors, basically they are cancers originating from an organ such as lungs, breast, prostate, thyroid, or other organs, and they are spread to the bones. So this is known either as metastatic bone disease or metastatic bone tumors. Around 1.2 million new cancers are diagnosed each year, and approximately 50% of them spread or metastasize. The incidence varies greatly with the primary site. The breast and prostate cancers account for around 70% of patients with metastatic disease. And in about 85% of patients with late-stage breast cancers, prostate, and lung cancers, we find metastasis. The gastrointestinal tract, if it's the primary site, they give rise to around 3 to 15% of metastasis. Other sites with high propensity of bone metastasis are thyroid, melanomas, or renal tumors. This is the presentation of the various tumors and the percentage, how much they metastasize. So as I told you before, the breast is around 85%, 50 to 85%. Prostate is around 50 to 70%. Hodgkin's lymphoma 50 to 70%. Lungs, kidneys are 30 to 50%. And thyroid is around 40%. Melanoma and bladder is around 30%, and bladder is around 12 to 25%. These are the typical sites of skeletal metastasis. Usually they affect the axial skeleton and involving the appendicular skeleton, it's the upper part of the femur or the humerus. This is how a blastic and a lytic mixed picture can appear. Areas of sclerosis and areas of lysis. So you can have multiple presentations of metastasis. This is a CT showing multiple metastasis. So metastatic process is generally completed in 3 phases. Number 1 is the breakaway of cancer cells from the primary tumor. Number 2 is adhesion to an invasion into a distant organ. And the last one is settlement in a bone microenvironment. So this is an example how a breast cancer, which originates from the breast and it is intravasated into the arteries or vessels, and here they are taken up by the immune system, where they strongly multiply and form small metastases, which are micrometastases, and they run into the blood again and go to the next organ, that is the bone, and that's extravasation. Extravasation will lead to establishment or colonization of the tumors. So a breast tumor will go from one stage to migration to intravasation to extravasation and then establishment. Similarly, if there is a primary bone tumor, the tumor cells will intravasate into the vessels. They will end up extravasating in the tissues, and the fate of the tumor cell will be either it will remain dormant, it may die, or it may go to the lung tissue, or it may go and form a micrometastasis. It's all on the adaptation of the tumor cell. So its fate lies on the adaptation. Once the micrometastasis has adapted, it will either again go into a dormant stage, it may die because of cell division, or it may again adapt and cause micrometastasis by vascularization. And this then evades the lung tissue or the secondaries where it forms. So this is the life cycle of a tumor metastasis. Skeletal malignancies, including bone metastasis, disrupt the OPG-Rankel signal translation pathway and promote enhanced osteoclastic formation, thereby accelerating bone resorption and inducing bone loss. This osteolysis is basically a vicious cycle. So the tumor cells and the osteoclasts not only lead to increased osteoclastogenesis, osteocavity, but they also aggressively grow and the tumor cells themselves multiply and cause a lot of growth of these cells. This is again an example of a tumor cell which has shown can show osteoblastic activity and end up as an osteoclastic precursor and finally act on the bone with osteoclasts. So again, as a result, these osteoclastic cells will release calcium, tumor growth factor, IGF, and growth factors, which can lead to growth of the tumor cells. So this is a vicious circle where the bone is eaten up and the tumor grows. For blastic activities, as I told you, the tumor cells also release certain factors which will cause growth of the osteoblastic cells, and then there will be more osteoblastic activity. So how would they present? Clinically, the patients usually present as pain, hypercalcemia, pathological factors, spinal cord decompression, behavioral moods like anxiety, depression, fatigue, and sleep disturbances, and deterioration of quality of life. This is how grossly appearing metastatic lung CA is seen in a humeral head. So I have talked many times in my previous talks that what investigation has what role. So I've just summarized this in a small slide that if we go for scintigraphy, you cannot find anatomical details. It sees the whole body. There will be appearing of the hot spots. So these hot spots can also give you false findings if there is rapid, purely osteolytic progression. And they can also give you false positive findings in trauma, inflammation, benign tumors, and healing. The diagnostic sensitivity is around 62 to 100%, and the specificity is around 70 to 100%. An X-ray will give you an anatomical detail. It will show you the local, regional. We can do a local or regional X-rays. This will show on appearance of the bone will be lytic or sclerotic, and what is the cause of false negative finding? If there is only involvement of the marrow, so and the lysis sclerosis not is at threshold for detection, because we know there should be a mass of bone which should be destroyed before it appears in the X-ray. So what will be the false positive finding will be in trauma, inflammation, benign tumors, or healing. So the sensitivity is around 50%. And it also shows you the clinical judgment and on the observer. A CT scan, yes, you can find the anatomical details. It is done local and regional. Appearance, you can see that it can be sclerotic, mixed, bone for higher, attenuation for marrow. Again, the false negative findings will be lysis, sclerosis, not at threshold for detection. The false positive findings can be in trauma, inflammation, benign tumors. Its sensitivity is around 71 to 100%, and as I told you, the diagnostic specificity, numerical specificity values are not addressed. MRI, yes, you can find the anatomical details. It's regional, so you can't see the whole body. It has got the appearance of the bone can be low or high intensity signals in T1, T2 signal, and the false negative findings region only in the cortex. And false positivity if there is edema in the tissues. So this can give you a false positive report. The accuracy for diagnostic sensitivity is around 82 to 100%, and specificity is around 73 to 100%. Then lastly, the PET scan. You cannot find the anatomical details. It takes the whole body. It will show you hot spots. The false negative finding will be lesion only in the cortex, and if somebody has had chemotherapy, there might be false positive findings. The sensitivity is around 60 to 100%, and the specificity is very high, it's around 96 to 100%. So this is our metastasis seen from a breast cancer. So the next step we do is get a biopsy. The indication it's indicated to rule out the primary tumor of the bone, and also the immunohistochemistry can determine the primary or metastatic disease. Biopsy at fracture site can be complicated by bleeding or callus formation, and it's a rule that culture should always be done to rule out infection. This is how a bone scan can appear. Management. Treatment only is often focused on managing symptoms of pain and bone weakness and not intended to cure. So it's a part of the orthopedics surgeon to give an easy life to the patient according to the life expectancy. The most common treatment options for metastatic bone disease include radiation, medications to control pain and prevent further spread of disease, and surgery is done to stabilize a weakened or broken bone. Besides chemotherapy and other medication, we also have a group of medications, the anti-resorptives like zoledronic acid, denosumab, and tamidronate. Looks a very busy slide, but I'll easily explain it. If there is an uncomplicated bone metastasis, if there is bone pain, we can start with these agents, and even if there is no pain, we can give them these agents, because these will prevent the SREs, the skeletally related events. Because what happens if the patient ends up in skeletally related events, the quality of life, the survival, and the treatment is a big challenge. So if the bone pain is complicated with bone metastasis, again, we use the same agents along with analgesics, and so these agents are known to slow down the progress of the tumor, give a better life, although they won't affect the longevity of the patient. So the only role of these agents is to prevent the SREs, as I told you before. Most common treatment options for metastatic bone include, as I told you, radiation and medications. And the following treatment options may be used concurrently: non-surgical treatments, medical treatments, and surgical treatments. I've talked about radiation therapy last time, so I'll just tell you the headings. The radiation therapy can be of various types. Local field radiation, where the most common type of radiation used, and the radiation is directed at the metastatic tumor and at the immediate adjacent tissue. The entire bone segments or multiple bones can be targeted to local field radiation, depending on how many areas are affected. The primary goal of radiation treatment is to relieve pain with minimal side effects. As I told you before, this is not for the treatment, it's for alleviation of pain and clinical symptoms. The local field radiation typically results in complete pain relief in around 50 to 60% of patients and partial relief in around 80% of patients. How well the metastatic bone disease responds to radiation depends on many things, including the cancer type. I mean, for example, breast cancers typically respond very well to radiation, while kidney cancers don't, and the location of the tumor as well. Then the second option will be hemibiotic radiation. This treatment involves a larger area of the limb, and rather than targeting specific bones, the half of the body is irradiated. Most metastatic cancer patients have multiple tumors, so hemibody irradiation is used to supplement local field radiation and may reduce the progression of widespread disease. Then the other option is radioisotope therapy. We'll ask Dr. Nadeem to give details about it. I just will tell you that it's an alternate to hemibody radiation. This involves injecting a radioactive medicine into a vein, and the areas of metastatic bone disease absorb the radiopharmaceutical agent, which then kills the tumor cells. Compared to hemibody irradiation, radioisotope therapy is easier to give and is also easier for the patients to tolerate. These are all the agents: phosphate, chloride, and a long list. I'm sure Dr. Nadeem will tell us about this. The medical therapy, again, in my previous lecture, I have given a detailed account on chemotherapy. So I would like you people to just go back and see that presentation. It's available on YouTube. So this treatment uses combination of various drugs to destroy cancer cells, and chemotherapy is done in cycles, which rest periods in between to let the blood cell count recover. All agents are covered in previous lecture. Okay. Then there are specific tumors like breast cancers or prostate cancers, which are also hormone dependent. So hormone dependent endocrine therapy is usually kept for those tumors, and they are treated by giving endocrine therapy. Again, as I mentioned before, there is a big role of bisphosphonates. Okay, so alongside these therapies, the most effective therapy is the surgical, and the surgical therapy aims towards prevention or relief of pain, to restore or improve motor function and improve the quality of life. So that if the patient has got metastatic disease, he's properly nursed, he can walk, he can sit, and can have an independent life. And the risk for impending fracture depends on the location of lesion, extent of lesion, if it's blastic or lytic, or if it's the primary cancer or the metastasis. Considering the peritrochanteric area is the most likely to cause a serious morbidity, and therefore the threshold for prophylactic fixation is for this region is very low. PMR accounts for 65% of all pathological fractures, and humerus and vertebra also requires special attention for patients' mobility. There is a Mirel scoring system. I'll let you know on the next slide. And this depends on clinical prediction of survival by knowing the primary site, the number of bone mets, involvement of viscera, and the hemoglobin level. This is a spinal compression shown by bone metastasis from the testes. Okay, this is the Mirel's criteria for prophylactic stabilization. Basically, if the score is given by the site, if it's upper limb 1, lower limb 2, peritrochanteric 3. So mild pain 1, moderate 2, severe 3, blastic makes 1, 2, 3, and if it's less than 1/3 of the cortex, if it's between 1/3, 2/3, and greater than 2/3. So for every score in first chart is score 1, 2, and 3. If the score is more than 8 or 9, we give prophylactic fixation. If it's below 7, we usually treat them conservatively. The gray area is the 8, so then there is clinical judgment where to fix and how to fix. Just a brief account on which region we do what. So if it's involving the scapula or clavicle, usually non-operative treatment is done. If it's involving the proximal humerus, we use a prosthesis long stem or intramedullary nail. If it's the diaphysis, we again use nails. If it's distal humerus, we can use flexible nails or bicondylar plates. Usually the forearm bones are fixed with IM nails, and these are rarely involved. For lower limb, if it's the acetabulum, then it's reconstruction with the appropriate customized prosthesis. If it's the femoral neck, which is the common part, we use a hemiarthroplasty, a THR, a cemented long stem prosthesis. If it's in intertrochanteric area, we can use a recon nail, or subtrochanteric, we can use an IM nail, a PFN. For a femoral shaft, we can use an IM nail, again a cephalomedullary nail, and if it's around the knee, we can use retrograde nails. This is an example of fixation. For the spine, usually the surgery is indicated if there is progression of disease after radiation, if there is neurological compromise, impending fracture, spinal instability due to pathological fracture, and progressive deformity due to pathological fractures. So the options can be minimally invasive kyphoplasty, vertebroplasty, or decompression and instrumentation. All is done for the patient's better life. Then the second part of my topic, that's multiple myeloma. I'll give you briefly the surgical management and something about the disease. As you all know, it's a monoclonal gammopathy and is the most common primary malignant neoplasm in adults. It usually arises from the red marrow due to the monoclonal proliferation of the plasma cells, and it is basically not really curable but can be controlled. Clinical presentation can be bone pains, anemia, renal failure, proteinuria, hypercalcemia, There is a mnemonic known as CRAB for increased calcium, renal failure, anemia, and bone pain. So it's easy to remember. Distribution, as we know, it depends on where the red marrow is. So it is richest in the vertebrae, ribs, skull. So its involvement is like this. And then it can also involve the shoulder, pelvis, the long bones, and extra osseous areas. This is a distribution. The violet ones show the typical, and the bluish ones show the atypical areas. Again, it involves the axial skeleton, proximal part of the shoulder and pelvic girdle. This is how grossly these lesions appear, lytic areas in the vertebrae. Again, as I told you before, it's a monoclonal proliferation of malignant plasma cells which produce immunoglobulins, commonly IgG, and infiltrate hemopoietic locations. That is the red bone marrow. The renal involvement is most common, and renal failure is usually due to obstructive casts, direct toxicity of Bence-Jones proteins, hypercalcemia, dehydration, hyperuricemia, amyloidosis. They all tend to cause renal failure. These are foci, gross picture of foci of multiple myeloma seen in the vertebrae. This is how they appear on the microscopic. On the microscope, you can see the plasma cell with the original Mott cell, plasma fill, and intracytoplasmic Russell body. And other features of plasmacytomas not apparent are a prominent perinuclear Golgi bodies and Toucher bodies. Multiple myeloma, which is diagnosed using several clinical criteria, is histologically a plasmacytoma. Imaging. So usually the multiple myeloma has two common radiological appearances, although it should be noted the initially radiograph may be normal despite the presence of symptoms. The two main different diffuse patterns are either well circumscribed lytic lesions or punched out lucencies, raindrop skull, endosteal scalloping, generalized osteopenia, you might see that, or compression of the vertebrae. This is how the raindrops appear, small spots on the skull on X-rays. A skeletal survey is essential not only for diagnosis of multiple myeloma but also in preempting potential complications. As I told you, the Mirel's criteria. So we need to see when to fix a fracture prophylactically or when to do it when it has fractured. The lesions are purely lytic, sharply defined, punched out with endosteal scalloping and abutting the cortex. Lesions are sclerotic in only 3% of patients. So these are the punched out lesions seen on this CT. This is an osteosclerosing variety of myeloma. You see widening areas. This is salt and pepper appearance on MRI, the black spots, and then there are the white spots. So for the other imaging tools will be bone scintigraphy. The larger lesions may either be hyperactive hot or photopenic cold. The bone scans may also be normal, therefore bone scans usually do not contribute much significance in the workup of the patient and establishment of disseminated multiple myeloma, as the sensitivity of detecting lesions is less than that of a plain X-ray. PET scan is effective in identifying the distribution of disease. So the uptake of FDG by the myeloma lesions corresponds to lytic bone lesions or soft tissue plasmacytomas seen on CT scan. However, focal high FDG uptake in the bone may be considered a positive lesion even in the absence of osteolysis. This is the typical appearance. You can see whole body scan with a positive presentation in active multiple myeloma and a negative scan. We can have a positive and a negative scan both. So how do we treat? The diagnosis After diagnosis, survival is around 3 to 5 years. The first line is vincristine, adromycin, doxorubicin, methotrexate, or bone marrow transplant. If there is relapse, again we use these long list of drugs with transplant. And with relapse and refractory disease, we give them supportive and palliative treatment, investigation therapy, and usually the deaths are around 12,000 per year. So these are the newer regimens. I'm sure Dr. Nala will help us in this. In the other tumor, which is comparatively very rare, is a chordoma. It's very uncommon malignant tumor of the axial skeleton. 1% is intracranial, is 4% of all primary bone tumors. It originates from the notochord. It arises in bone, usually extradural, which is locally aggressive but uncommonly metastasizes. Epidemiology, there are the two varieties. One variety is the spheno-occipital chordomas, which are in younger age, and the sacrococcygeal chordomas, which are in older age, more than 50 years. So these are slow growing tumors, and usually they have a mass effect on the adjacent structures. So how would you see them? There will be firm masses, fluid and gelatinous mucoid tissue. I'll show you in a slide, and they may be calcified and sequestered bony fragments may be found due to pressure, and physalophorus cells can also be seen. This is how they will appear as large vacuoles with malignant cells. Then there are three subtypes. One is the conventional, which is the most common, the chondroid, which has the best prognosis, and the dedifferentiated, which is the least common and worst prognosis. As I told you, sacrococcygeal area is around 30 to 50%. Spheno-occipital area is 30 to 35% area. The involvement, and vertebral body is 15 to 30%. And it should be remembered that it is the most common primary malignant tumor of the sacrum. This is how it appears on the back of a patient. After removal, you see a large mass which was giving pressure symptoms. So usually the imaging done is a CT or an MRI. The MRI has the best chance to see. This is how the lesion will appear. Treatment is usually surgery, radiation therapy, multidisciplinary approaches needed. We might need big flaps because of after removal we have big gaps, and medical treatment as such has not yet been found. So the gold standard is en bloc excision with wide margins and post-op external beam radiation. Lastly, I'll present you rhabdomyosarcoma. It's a malignant tumor of muscular origin, usually seen in children. 5% of childhood cancers, 19% of all pediatric soft tissue sarcomas. It is associated with a number of diseases, but usually found in neurofibromatosis, Beck-Smith, Weidman syndrome, Costello syndrome, and maternal use of cocaine and marijuana is also reported. These are rapidly growing masses of muscles which cause localized pressure. There's predilection for infiltration of bones, and in children and adults, they usually involve the head, neck, and pelvis. These on pathology they resemble skeletal muscles, but don't arise from it. They have three types: the embryonal, the most common, the alveolar, and the pleomorphic. This is how they appear on the microscopy. Location, as I told you, head and neck 50%, genitoury 25%, extremities 15%. This is how grossly it appears: a large swelling on the back of the thigh and giving pressure symptoms. This is seen in the MRI. So it has got 4 stages. Stage 1 involves the orbit, eyelids, and head and neck. Stage 2, bladder, prostate. 3 is bladder, prostate, and extremities. Trunk, parameningeal areas. So if it's less than 5 centimeters, stage 2. If it's more than 5 centimeters, is stage 3. And if there is any involvement of nodes or metastasis, then it's stage 4. The treatment and prognosis, usually the treatment choice is surgery, chemotherapy and radiotherapy. 20% have metastasis at the time of diagnosis and 5 years later 75%.